Good afternoon everyone. I am Dr. Aarushi and today I will be presenting a case on manual INTACS in keratoconus. So a 19-year-old female presented to OPD of the hospital Bhiwani with the chief complaints of blurring of vision and frequent change of glasses since 3 years. There was no other significant history except for chronic ocular allergy which was associated with frequent eye rubbing since childhood only. The ocular examination, the unaided visual acuity was 6 by 12 in the right eye and 6 by 36 in the left eye. On retinoscopy, scissoring reflex was seen in both the eyes, and the anterior segment was within the normal limits, and best corrected visual acuity was 6 by 6 in the right eye and 6 by 9 parts in the left eye. After that, pentagram was done for both the eyes, which came to the conclusion that the patient is suffering from bilateral keratoconus, more pronounced in the left eye than the right eye. And the procedure planned was left eye manual INTACS implantation and right eye C3R. So the surgical nomogram was prepared, and according to the patient parameters, 0.45 mm INTACS SK segment in the inferior section was planned. So here we go with the procedure. This is centration is done, central marking is done, and after that we do the segment placement marking. The diamond knife is set at the 70% of the corneal thickness and incision is given vertically. After that the pocket creation is done and dissection is carried out with help of the spreader. Tunnel is created once in clockwise direction, then in anti-clockwise direction, and the INTACS delivery is done with the help of McPherson forceps, and Sinski hook helps in the subsequent placement of the ring segment. So what we see that pre-operatively the left eye vision was 6 by 36, which was improving to 6 by 9 parts. Status post day 1, the left eye vision was 6 by 12 parts, which was correcting to 6 by 6 parts, and status post 1 week the left eye vision was 6 by 12, which was improving to 6 by 6 parts again. Status post INTACS 1 month, the INTACS ring was in place, the vision was stable and no segment migration or exclusion was seen. Unaided visual acuity of the left eye was 6 by 12 and of right eye was 6 by 9 parts, and the glasses prescribed were -1 cylinder at 115 degrees in the right eye, and in left eye it was spherical -2.50 with the BCVA of 6 by 6 in the right eye and 6 by 6 parts in the left eye. So here we can see that the post-op period of the patient was uneventful in status post 1 month follow-up as well. So this brings us to conclusion that manual INTACS are a viable option for the young patients who have keratoconus, who have central clear corneas, and who are intolerant to contact lenses. It's just that the patient selection criteria is important, and what INTACS does is it helps flattening the cornea in the area of protrusion and reduce the astigmatism by the arc shortening effect. And there are some contraindications of the procedure as well. That is, if there is central corneal scarring, herpetic keratitis, and if there are some connective tissue disorders along with the pregnancy, and also if patient is on drugs like sumatriptan, so for migraine, so also in those cases the manual INTACS is contraindicated. Also it delays the need of penetrating keratoplasty, and the added benefit is reversibility. Thank you.
Thank you, Dr. Aarushi, for excellent presentation and excellent outcome of this case with the manual intact. What was the age of the patient?
Sir, 19 years.
So, did we combine collagen cross-linking with the INTACS or?
No, sir. Sir, for right eye it was planned. It was advised to the patient that she combines C3R with INTACS in the left eye as well, but she was not really willing.
Okay, so it's basically the two things are different. INTACS will take care of the astigmatism part and will decrease the irregular astigmatism, but progression of the disease will be arrested only by the collagen cross-linking. So that part has to be kept in mind. Anyway, thank you so much.